Hi class, welcome to lecture 3. Today we're going to be talking about data disease surveillance and some dynamics of disease transmission. Before we get started, just housekeeping reminder, you guys do have a quiz tomorrow. In order to prepare for your quiz, I would recommend just reviewing the slides. You are going to be asked to calculate incidence and prevalence, and again, it's not going to be, the quiz won't cover content, it will cover concepts. So you won't need to know things from the articles that you've read, but you will need to know things like the descriptive versus analytic, incidence versus prevalence. So the context, the topics that we've gone over. The second thing is that your city certificate and practica forms need to be brought to me to class on Monday, July 25th, and I believe that Erin's going to be covering or going over helping you guys get the city certificates and practica forms done this week. Right, and lastly, our discussion leaders for today. Okay, so the first thing I'm going to do is start by reviewing incidence and prevalence and reviewing the answers to the worksheet that you guys did yesterday, or perhaps today if you're moving a little slower. So what is incidence? Incidence is going to be the number of new cases that occur within a defined observation period. So within a defined observation period, that's telling us that there's some measure of time here, number of new cases within a period. So if I said there was 24 new cases of gonorrhea in June of 2015, there's two pieces of information there, right? There's one, just the number of new cases, and two, there's a time period, and a time period with a beginning and an end. Now, if I'm going to calculate an incidence rate, I need to know the number of new cases and the population at risk. And the population at risk is going to be persons who are capable of developing disease. So if someone already has the disease, they're no longer at risk. So an incidence rate is, in our numerator, the number of new cases within a time period over your denominator is the total population at risk at the beginning of the time period. So if we were going on with this gonorrhea example, I would say I would want the number of new cases of gonorrhea in June of 2015, and in the denominator, I would want the number of people at the beginning of June of 2015 who are at risk, so who do not have gonorrhea. Persons who have gonorrhea at the beginning of June of 2015 are no longer at risk. All right, so in this example, we were saying there was 24 new cases of gonorrhea in June 2015, over 100,000 persons at risk of in June of 2015. This gives you an incidence rate of 0.00024 cases of gonorrhea. Because this number is hard to interpret, what you'll usually see is an incidence rate expressed per some population. So per 10,000 population, per 100,000 population. And to express something per 100 or per 10,000 population, all you need to do is times this 0.0024 by that number. All right, so on to prevalence. Now, prevalence is going to be the total number of cases, of existing cases at a point in time. So this is all cases as opposed to new cases and incidents. And this is a point in time as opposed to a time period for incidents. So your numerator is the number of cases. Your denominator is the total population. And for this example, we have 500 schools at School A with spring fever, over 5,000 students at School A. So we don't care when these people developed spring fever. We're just saying there was 500 students at School A who had spring fever, and a total of 5,000 students at School A to give you a prevalence of 0.10 students with spring fever. So 1 in 10 students. Okay, so this should be how you set up your table from yesterday. Now, the first thing you are asked to do is calculate the incidence rate. So in the second column, we have the number of new cases. And in the fourth column, 1, 2, 3, 4, we have the number at risk. So to calculate the incidence, you take your numerator over your denominator. So 55 over 3,535 in in year 1. In year 2, we have 50 over 3,430. And again, an incidence rate is going to tell you how fast people are becoming a case. Now, what about the point prevalence? So that's the very last column. Well, for point prevalence, what we want is the total cases over the total population. So, and again, this tells you how many cases you have in total. It's not telling you anything about how quickly disease is developing. It's just giving you sort of a snapshot of the disease burden at a point in time. So for year 1, our total number of cases is 55. The total number of people, total number of students in the school is 3,535. So the total number of students here is never changing. So for this example, what you're doing is assuming that no one's ever moving in. There's no students moving into the school, and no students are leaving the school. So 55 over 3,535 is your prevalence for year 1. For year 2, it's 105 over 3,535, and so on. Now, I think the one thing that could have potentially tripped you up here or confused you is figuring out the number at risk for year 1, right? So let's go back to the incidence slide. Now, the number at risk in year 1 at the start of year 1 is 3,480. And why is it 3,480? Because you need to subtract these 55 people from the total number at risk, or from your total, sorry, from this total number, right? So you take 3,535 minus 55 to get 3,480 who are at risk at the beginning of the first year. And why? Because in year 0, or in year 1, you have 55 people develop the disease. So new cases over number at risk. So this is from the prior year. Right, the last thing you were asked to do, oops, is is to express these incidence rates. So now these two columns, the incidence rate and the point prevalence, are going to be the first two columns in my next table. So incidence rate, point prevalence. You were asked to express these per some annual incidence. So if we were going to do per 100, we would take the 0.0156 and the prevalence 0.0156 and times it by 100. If we were going to do per 1,000, we would take 0.0156 times 1,000. And as I'm looking at this, I see that I actually wrote up here in this column, annual incidence per 100 population. This should be per 1,000 population. And why do we know that? If you take 0.0156, move the decimal over 3 places, you'd get 15.6. So this is per 1,000 population. 14.4 also, these are all per 1,000 population. In fact, let me just change that on the slide for you right now. Okay. All right, again, so now I'm going to start the second half, or the lecture for today. But if there's questions about any of that, please email me, because you will see this on your quiz. All right, so the objectives for today is first you're going to understand where to find data and reliable information on health conditions. Second, to understand the role of public health surveillance. And related to that, I'm going to show you epiquery. I imagine, though, by now that Erin might also have shown you epiquery. You'll be using it a lot for the morning half of this class. And then we'll go over some of the basics for disease transmission. And then I actually have STI overview on here. I'm not going to do that this year. I'm just going to go over some of the STI epidemiology, and then have you guys do the in-class assignment. All right, so in terms of online sources of epidemiological information, where should you go to look for data, and where should you go to look for articles for your midterm project? I would suggest any of these websites, and when I get back, actually, I'll give you a little bit of a tutorial over how you should be looking for articles, but basically these are the sources you can use: CDC, the World Health Organization, Google Scholar, PubMed, Medline. Now moving on to surveillance. So surveillance is systematic and routine data collected on systematic and routine data collected. So we collect surveillance information on vital events. So deaths, births, fetal deaths, marriages, divorces. Now deaths, routine data collected on all deaths occurs across the United States. So there's national death surveillance. There's also local death surveillance. So in New York City, they have a death registry, and then there's also the National Death Registry. And what's reported to the death registries are usually just the certificate of death. And the interesting thing to keep in mind, if you guys are going to look at death data, is that a certificate of death is typically completed by a funeral director. So it's not always like a medical professional that's completing a death certificate. The physician will usually complete the section on date and cause of death, and the medical examiner or coroner will complete and sign the death certificate if death occurs to accident, suicide, or homicide. And these rules kind of change actually from state to state. So nationally, we don't have systematic collection of we have systematic collection of death data, but the way it occurs varies from state to state. The National Center for Health Statistics is responsible for collecting all the death information. And the other thing that's pretty interesting about death data is that it's publicly available. So your information is personal, all your personal information is private until you die, at which case it becomes publicly available information. So you can look up death certificates on anyone. But really the question you should wonder and be thinking about in terms of your projects too is, do you want data, and why would you want death data? And we use it because it's one of the most common indices of public health. So if you think about tracking things in tracking trends in cardiovascular deaths, injury deaths, suicides. It becomes one of our most important outcomes, right? Actually, maybe the most important outcomes. Are people dying quicker? Are people dying from certain diseases at a higher, with increased frequency? And yesterday we went over the suicide slide set, and you see actually with suicides that that death rates are increasing. The last thing you should know about death data is just that there's a lot of problems. So I alluded to this a little bit earlier when I said that states don't systematically record the information in the same way. All deaths are documented, but it might not be documented in the same way. The other problem is that the cause of death may be unclear. So diabetes, may not be the death, may be the cause of death, but the death certificate might actually list heart failure or pneumonia. So again, these are completed by physicians, the section on date and cause of death, but they've done lots of studies to sort of show that there's a lot of heterogeneity in how a physician, even like physicians within a certain hospital, will determine a cause of death. So, and if you think about things like chronic disease, it gets kind of hard to determine the cause of death. You know, was it the diabetes that caused the death, or was it the heart condition? And a lot of these things are occurring at the same time. So whittling it down to one condition is tricky. The other problem with death data is that there's a lack of standardization of diagnostic criteria for determining death, which is sort of circularly related to the cause of death being unclear. So what that means is that sometimes people won't want to record the actual cause of death. So some physicians might be reluctant to mention that death was the result of suicide. When the HIV epidemic was starting, and a lot of young men and young women were dying from AIDS, there was quite a few physicians who wouldn't document the death as due to AIDS on the death certificate. And sometimes it was because, you know, the physician was a friend of the family and they didn't want this. And again, you have to keep in mind that all death information is public information. They didn't want to sort of put that, because AIDS is such a stigmatized, and suicide are such stigmatized conditions, they didn't want to document that as a true cause of death. All right, the other vital statistic we collect information on is births. So this includes live births and fetal deaths. And why do we want birth certificates? Well, mostly just to calculate birth rates, right? To understand how quickly the population is growing and how quickly the population is changing, and also to understand conditions that affect neonates. So those are those less than 4 weeks. And we use the dates to search for clusters of birth defects in geographic areas where mothers may have been, for the fetal deaths, where mothers may have been exposed to agents that might cause fetal malformation. So you can think about like carcinogens or toxins. Tracking fetal deaths is useful if we're looking for clusters. Okay, so all this vital statistics information is part of, broadly part of public health surveillance. And the definition your book is using for public health surveillance, and the definition I would like you to know, is that it's systematic and continuous gathering of information on diseases and health conditions. And it's systematic because you're doing it in some sort of systematic way, and continuous because you're not just doing it one day, you're doing it over time. You're continuously gathering all of this information. And again, similar to the death and the birth data, we want this information to inform, to help us understand the population, to inform program planning, resource allocation, and to track disease burden. So I work very closely with HIV surveillance data, and we if you think about HIV surveillance, you would want to know the number of new cases in any given year in order to sort of inform the people who are providing service, in order to help them inform their program planning and allocate their resources. If they only have so much money on a grant, and they want to know what the best way is to target the limited resources they have, they need to know how big the disease burden is. So we do public health surveillance, disease surveillance for what we call reportable and notifiable diseases. So healthcare providers, and this is usually news to a lot of people, are legally required to report some diseases and health conditions to the government. This is typically infectious and or dangerous diseases, so you can, or those that are contagious. So things like STDs, measles, plague, hepatitis, anthrax, botulism, tuberculosis, HIV. All of these diseases are reported to the government. So, and again, why do we want to track certain diseases? Well, for disease control, right? You can't understand the disease if we don't know who has it. You can't control the disease, the outbreak, if we don't know who has it. And the other thing is just for outbreak investigation to determine if the level of cases is rising above what we would normally expect to be occurring. Now, syndromic surveillance uses health-related data that precedes a diagnosis to signal a sufficient probability of a case later occurring or an outbreak in order to warrant sort of further public health response. And we do syndromic surveillance for syndromes. And the idea here is that you're going to be able to detect outbreaks a little bit earlier than what you would otherwise. At the New York City Health Department, they do syndromic surveillance for unusual disease clusters, some sentinel events, and bioterrorism. And the way you can think of syndromic surveillance is sort of like a canary in the coal mine. So the idea being that, if you took a canary down into a coal mine, it would warn the coal mine workers of carbon monoxide poisoning in the mines. So the canary would die in the coal mine before the level of carbon monoxide poisoning would reach a level that's hazardous to the mine workers. So if the canary dies, then the coal mine workers know to leave. It's the same idea with syndromic surveillance. You're trying to identify maybe like GI syndromes that are occurring that might pop up before some sort of salmonella outbreak. Now, New York City has had syndromic surveillance in place since 1995. All emergency departments, almost all emergency departments, so 98% of all emergency room visits are captured in the syndromic surveillance system. And the syndromes that they collect information on are influenza-like illness, vomiting, diarrhea, respiratory illnesses. So this is actually data from the New York City syndromic surveillance when they were setting it up. And what you can see here in this top row is sort of the trends so this is respiratory data. So this is a synthetic data set on top, and you would see the trends that they would expect in the emergency department in terms of respiratory illnesses. So it's pretty hard to see the months down here, but we could guess that, when these peaks are occurring, it's in the winter. The low points is in the summer, peaks in the winter, low points in the warmer weather, peaks when it's getting cold. Now, if we look at the actual data down here, it looks pretty similar, right? Until right about here when you get this big peak. And this is what syndromic surveillance is supposed to help you do. You see something unusual, and then you know that there's something going on, and then the goal is to figure out what it is. Like, is there a new strain of influenza? Is there, since this is respiratory, that might be what you would assume. If it was GI, is there a big like outbreak occurring? GI, is there a big food outbreak occurring? All right, the last thing in the surveillance section that I want you to be aware of is the EpiQuery website. I'm not going to go to, well, wait, maybe I will quickly. Let me switch the screen to it for. All right, so this is EpiQuery. And this is all of the publicly available surveillance information that the city provides. So you are not going to be able to look at like a line listing of who has what conditions, but you can look at aggregate summaries, which is really useful. So for your projects, I'm going to go into the community health survey module. Maybe, let's pick one. Maybe you're going to do a project on asthma. And you have the option for looking at age-adjusted estimates or unadjusted estimates, which we covered on Tuesday. All right, and this is going to just give you the age-adjusted prevalence of adults. You can also sort of select some demographics to look at this. So maybe we want to look at asthma by age group and neighborhood poverty. So this is showing us that 11.3% of adults in 2014 had asthma. All right, and here we see that among 18 to 24-year-olds in low poverty, so the wealthiest neighborhoods, 8.9% of them have asthma. Among 18 to 24-year-olds in high poverty, 18.5% of them reported having asthma. And if you think about asthma and the conditions that sort of we think might cause asthma, this makes sense, right? Things like your higher poverty neighborhoods are going to have, sometimes will have more, also more, you're living in lower quality housing, so things like roaches are going to be a problem, and roaches are related to seeing higher incidence of asthma. So, and the other thing here that this shows you is a pretty big disparity, right, in young persons in the low poverty to the high poverty neighborhoods. That's almost double the prevalence here ever having asthma, 8.9% versus 19%. All right, so if you guys haven't already played around with this data, this EpiQuery website, I imagine you will be soon in the morning session, and you will also have to pull some information from here for your midterm. All right, and now I'm going to switch back to the lecture slides. The next thing we're going to talk about is quarantine, which is, related to disease surveillance. So CDC is responsible for preventing the introduction, transmission, and spread of communicable diseases from foreign countries into the United States, and also from preventing the spread of disease within the United States and its territories. CDC issues very few, actually, federal isolation orders in a year, and it's usually for persons who come in with infectious tuberculosis. But in most cases, quarantine is left up to the states. So in the event of some sort of conflict between the state and the federal powers, then the federal law is supreme. So when you hear the word isolation, what that means is actually separating sick people from healthy people. If you hear the word quarantine, It means separating and restricting the movement of people who were exposed to a contagion to see if they become sick. So you're quarantined before you become sick. You're isolated if you're actually contagious. So, and there's only some communicable diseases for which apprehension and detention of persons are authorized. And when this happens, it's actually by executive order of the president. And the diseases include cholera, diphtheria, infectious tuberculosis, plague, smallpox, yellow fever, viral hemorrhagic fever. And that includes things like Ebola, Lassa, and Marburg, and others that have not been isolated or named, SARS and influenza from a novel or reemergent source. And again, it's very, very rare to issue an order. So quarantine law began in 1663 in New York, and the reason that they developed quarantine law was to control a smallpox outbreak. The problem with quarantine is that it raises a lot of issues of civil rights, particularly in instances of long segregation. And I think the most infamous case here is Typhoid Mary. So Mary was the first person in the US to be identified as an asymptomatic carrier of the pathogen associated with typhoid fever. She's presumed to have infected at least 51 people, three of whom died. And she was twice forcibly isolated. So in the first time she was isolated, she was working as a cook in New York City and on Long Island for a bunch of families. And of course, all these families that she was working for would get ill while she was there as a cook. They'd have some sort of typhoid outbreak, and then Mary would leave. Eventually, one of the families ended up hiring an investigator, a typhoid researcher, and he noted that 3 weeks before the family had this big typhoid outbreak that they had hired Mary, this new cook, and that she left shortly after the outbreak had occurred. And this researcher, was the first to suspect that Mary was the reason for this outbreak. And he went around and he asked all these other families that had also hired Mary if they had had typhoid outbreaks. So when the researcher finally talked to Mary, she admitted to having poor hygiene. She didn't believe in she didn't believe in microorganisms, so she didn't believe in washing her hand. And what ended up happening, and this is the first time she was isolated, is that the health department got involved and took her to Brother Island, which is in the East River and is north of Manhattan. And they put her there for 3 years. At which point Mary convinced the clinician in this facility that she was staying in that she wouldn't work in a kitchen ever again, and she would basically that she wouldn't work in a kitchen ever again. So they released her, and almost immediately after she was released, she started working in a kitchen for a hospital. And the hospital had a big outbreak, and at which point they forcibly isolated her for the second time, and she remained in isolation for the rest of her life. So in total, Mary spent almost 3 decades in isolation. She did sort of develop minor celebrity. They would interview her every year. Mary never actually believed that she was an asymptomatic carrier of the pathogen. She wouldn't let them remove her gallbladder. She wouldn't let them take samples. She just felt like she was being held against her will, and she didn't think that because she wasn't ill, she didn't think that she was causing all this illness. Okay, so disease does not arise in a vacuum. So sort of in the Mary example, right? Mary's the reason for all these typhoid outbreaks. What you commonly see with infectious disease is what we call the epidemiologic triad. And it's the interaction of some sort of host, agent, and environment. So and sometimes a vector. For example, a mosquito could be involved. So the host, the person who has some sort of genomic susceptibility, or perhaps resilience to infection. The agent, here the example shown is cigarettes, but I think it's easy to think of agent as your microorganisms, your bacteria and your viruses that interacts with a host who could or could not be susceptible. And the environment. So, and why does the environment matter? Well, a lot of agents are only infectious in or only really arise in certain environments. So if the environment is unhygienic or if you don't have a clean indoor air policy. And vectors being things like mosquitoes that transmit disease, or things like, you know, deer tick and Lyme disease. In terms of modes of disease transmission, we have a few. So direct is person to person. So indirect means there's some sort of common vehicle. So contaminated air or water, or having a vector. So mosquito transmitted or tick transmission. And different organisms spread different ways. So you need to understand the mode of transmission if you want to stop disease transmission. Outbreaks really depend on a lot of characteristics, but two important ones are the rate of organism growth and the route of. Is it direct? Is it when you use hands, or is it indirect? Is it when you touch the coffee table? And there's sort of also this, what you'll hear referred to as the iceberg concept of disease. So this idea that some diseases are clinical, and then there's also subclinical disease. Now, only clinical disease is readily apparent, so we could argue that Mary Malone had subclinical disease. She was infectious without being clinically ill. So she never experienced any mild or severe disease. And again, these things matter in terms of disease transmission, because obviously people with clinical disease are going to be easier to identify in order to stop disease transmission. People with subclinical disease, right, like Mary hopping all over Long Island, infecting family after family, it's trickier to figure out what's going on then. And in terms of subclinical, the inapparent disease, we sort of have two stages. That being, there's one preclinical where where disease is not yet clinically apparent, but it's destined to progress to clinical disease, and subclinical, where it's not clinically apparent, not destined to become clinically apparent. So Mary would have been subclinical. And why are infections without clinical illness important? And again, it's to understand transmission in order to prevent disease. And importantly, if we want to understand the incidence rate or the true prevalence of a disease, then it's not sufficient to count only the cases we can see. In HIV surveillance, what this means is that a lot of people are still undiagnosed, right? So living with what we would say preclinical disease. So they haven't yet advanced to where the HIV virus is making them feel ill, or they haven't advanced to AIDS. But if you were trying to understand the epidemic, if you're trying to end the epidemic of AIDS, then you need to know who's undiagnosed, who is preclinical. Yeah, I guess two other examples here are polio. So prior to having the vaccine, most cases of polio were actually subclinical. So not going to progress to disease, but they were still capable of spreading disease. So they sort of like Mary again. And the epidemiology of polio and eradicating the polio epidemic, eradicating the polio disease can't be explained without recognition and assessment of the pool of subclinical cases. Tuberculosis is sort of similar in that it's often subclinical and not apparent who has tuberculosis, because tuberculosis isn't always infectious. All right, the last thing, well, not the next thing I'm going to talk about is some ethical violations in public health. And the reason I'm talking to you about this is because I'm asking you to turn in this to do your city certificate. And the reason you have to do a city certificate is because of these ethical violations that have occurred. So I'm going to talk to you a little bit about the most notorious ethical violation, which was the Tuskegee study. So syphilis is an STD bacterial agent, and it sort of has three phases of the infection. The first is primary, which is a lesion. The secondary stage of the infection is typically a rash that occurs on the palms of the hands and the feet. And some infections will progress to the tertiary stage, which is, it's very serious. It can actually kill you. So 20 years, around usually 20 years after initial infection, you'd progress into the tertiary stage, and it damages your internal organs, including the brain, nerves, eyes, hearts, blood vessels, liver, bones, and joints. And symptoms of late stage syphilis include difficulty coordinating muscle movements, paralysis, numbness, gradual blindness, dementia, and the damage can be severe enough to cause death. All right, so this is, and when this occurs, when you get into this third stage, it's often referred to as neurosyphilis. And it can actually look like Parkinson's or Huntington's disease. So the Tuskegee study started in the 30s, and the reason they started was to understand the natural history of syphilis. So the progression of untreated syphilis, and it was a progression of untreated syphilis in 600 Black men who were living in Alabama, and they started this study under the guise of receiving free health care from the US government. The study went on for 40 years, and the men were given free medical care, free meals, sort of free transportation for participating. But none of the men were actually ever told that they had syphilis. So in the late 1940s, penicillin was validated as an effective treatment for syphilis. But the study coordinators didn't actually offer penicillin to any of the men, right? Because remember, what they wanted to do was study the natural untreated history of syphilis. And even after funding for the study was lost, the study continued on without informing the men that they had syphilis and that they weren't being treated. So what happens is in the 1970s, a whistleblower comes forward and basically tells on these study investigators, and this leads to major changes in U.S. laws and regulations on the protection of human subjects, which is why we now go through IRBs. Ultimately, all these men who were enrolled in this study ended up filing a class action lawsuit. Although by the time they filed the lawsuit and actually won the lawsuit, most of them had died. They got $10 million plus lifetime medical treatment and burial services that was provided to the participants and to the participants' families. So this is why we now have what we call human subject review boards. And what you guys are completing, this city certification, is for me to present to a human subject review board. And the reason we're doing it is because I'm going to tell them that this data you're collecting is for a class project, not actually for the purposes of research. You guys cannot use this data you'll be collecting for publication or for publication or for research. So outside of the classroom, you can't do anything with this data. This is just for the purposes of learning. And these things you should be reading about while you're going through city certification are minimizing risks and protecting welfare of human subjects, why we obtain informed consent, why studies are submitted for ethical review. And we have to do this as public health investigators in order to maintain public trust and to meet the obligations to the communities, right? So in Tuskegee, the investigators most definitely didn't meet any sort of obligations for the community. Okay, so I'm going to pause here, and then I'm going to open up Actually, I'm going to stop here and then start another recording, and we'll briefly review the CDC STD surveillance slide set, and I'll give you your class assignment for today.